In this video, we will speak about the normal ECG. Sinus rhythm refers to a heart rhythm that originates from the sinoatrial node, also called the sinus node. It is the normal cardiac rhythm. If a positive P wave precedes each QRS complex in leads 1, 2, 3, IVF, except AVR, and has a constant shape, then the heart is beating in sinus rhythm. However, there may be some variation in the PP and RR intervals. Typically, heart rate increases during inspiration and decreases during expiration. This phenomenon is called sinus arrhythmia and is more common in young people, especially children. Sinus arrhythmia is less prominent in the elderly. The terms bradycardia and tachycardia should be used with caution because there are no definitive normal heart rate values. Many authors believe that a normal heart rate ranges from 60 to 100 beats per minute. However, it may be less than 60 beats per minute in healthy, fit individuals. In this ECG, the heart rate of an athlete is 47 beats per minute. A heart rate exceeding 100 beats per minute may be observed during pregnancy, anxiety, and other physiological states. This ECG shows sinus tachycardia associated with anxiety. The heart rate is 116 beats per minute. This ECG was recorded during physical exertion. Physiological causes of sinus tachycardia include exercise, anxiety, fright, lack of fitness, and pregnancy. The P wave reflects atrial depolarization. Typically, the P wave is positive in all leads except AVR. Occasionally, it may be negative in lead AVL. Some healthy individuals have a biphasic P wave in lead V1, however, the duration of the terminal P wave negativity is less than 40 milliseconds, and the depth is less than 1 millimeter. The P wave width should not exceed 120 milliseconds. Typically, the amplitude of the P wave is less than 2.5 millimeters in the limb leads and less than 1.5 millimeters in the precordial leads. Bifid or peaked P waves are sometimes seen in healthy people. This ECG shows a biphasic P wave in lead V1. The terminal P wave negativity duration is less than 40 milliseconds, and the depth is less than 1 millimeter. The PR interval reflects conduction from the atria to the ventricles. A delay in the atrioventricular node accounts for most of the PR interval. At rest, the PR interval normally ranges from 120 to 200 milliseconds. During exercise, it may shorten to 100 to 110 milliseconds. The PR interval on this ECG is 200 milliseconds. This is the lower limit of the normal PR interval. Occasionally, the PR interval may slightly exceed 200 milliseconds in healthy individuals, particularly athletes. Such prolongation is of no clinical significance in the absence of evidence of heart disease. The QRS complex represents ventricular depolarization. A normal QRS complex is less than 100 milliseconds wide, though it may be up to 110 milliseconds wide in some healthy individuals. However, a width of 120 milliseconds or more is required for the diagnosis of the bundle branch block. Prolongation of the QRS complex indicates that more time is needed for ventricular contraction. This is usually caused by asynchronous depolarization of the ventricular walls. The QRS complex width on this ECG is 110 milliseconds. The normal cardiac axis ranges from 0 to 90 degrees. In other words, there are dominant R waves in leads I and AVF. Occasionally, a slight left axis deviation is observed in healthy individuals. The cardiac axis on this ECG is plus 4 degrees. Physiological left axis deviation refers to a cardiac axis between minus 30 and 0 degrees. This is often seen in obese patients and during pregnancy. With physiological left axis deviation, the R wave amplitude should be greater than the S wave amplitude in lead 2. However, in this case, the amplitude of the S wave exceeds that of the R wave. If the R and S wave amplitudes in lead I are equal, the cardiac axis is at its rightward limit of normality. In healthy individuals, the S wave amplitude may occasionally exceed the R wave amplitude in lead I. The high amplitude of the R waves in the limb leads and left precordial leads, as well as the high amplitude of the S waves in the right precordial leads, indicate left ventricular hypertrophy. This is often seen in thin young people. Sometimes, extremely high R waves in certain leads merge with S waves, or even R waves, in adjacent leads. In this case, it is impossible to measure the amplitude of these waves. An ECG recorded at half sensitivity can help in such cases. Typically, the transition point, the precordial lead with equal R and S wave amplitudes, is seen in leads V3 or V4. However, it is often seen in leads V2 or V5 in healthy individuals. Additionally, incorrect placement of the precordial electrodes can result in clockwise or counterclockwise rotation. This should always be excluded. Occasionally, Q waves similar to those seen in myocardial infarction are present in lead-3 in healthy subjects. Rarely, Q waves are also seen in lead AVF. However, these Q waves are narrower and less deep. They disappear during inspiration and are called positional Q waves. During inspiration, the R wave in the inferior leads tends to increase in amplitude. Tiny Q waves, which have the largest amplitude in leads V4-V6, are caused by the depolarization of the ventricular septum. These waves are called septal. They are often seen in healthy individuals. Typically, the ST segment is isoelectric. However, concave ST segment elevation or slight ST segment depression may also be present. ST segment elevation following an S wave in the precordial leads is called a high takeoff ST segment. This is a normal variant. In healthy individuals, ST segment depression never exceeds 2 mm and is usually upsloping. Normally, the T wave is positive in all leads except AVR. The T wave may be inverted in leads 3 and V1. T wave inversion in lead 3 may disappear during deep inspiration. If the T wave is inverted in lead 3, it should be positive in lead AVF in healthy individuals. T wave inversion in lead AVL is also considered normal. Usually, if there is an inverted T wave in lead AVL, the P wave is inverted as well. T wave inversion in leads V2-V3 is normal in people of African descent. It is rarely observed in healthy Caucasians. When T waves are inverted in leads V2-V3 in Caucasians, pulmonary embolism, right ventricular hypertrophy, and coronary artery disease should be considered. Peak T waves are often seen in patients with hyperkalemia but may also be seen in healthy individuals. Widespread T wave flattening in asymptomatic patients with clinically normal hearts is normal. A prominent U wave can lead to incorrect QT interval measurements. Sometimes, it resembles an additional hump at the end of the T wave. In healthy men, the QTC interval ranges from 350 to 440 milliseconds, and in healthy women, it ranges from 350 to 460 milliseconds. Some authors consider values between 430 and 450 milliseconds in men and between 450 and 470 milliseconds to be normal. The QTC interval calculated using the Bazet formula is inconclusive for patients with sinus tachycardia, atrial fibrillation with a rapid ventricular response, and many other types of tachycardia. For these patients, the Fredericia or Framingham formulas are more accurate. These formulas are more complex, so online calculators are typically used. The QT interval is 340 milliseconds. The QTC interval calculated using the Bazet formula is 475 milliseconds. The QTC interval calculated using the Fredericia and Framingham formulas is 425 and 415 milliseconds, respectively. Bazet's formula is inappropriate for patients with bradycardia. The Fredericia and Framingham formulas are more accurate in this case. The QT interval is 510 milliseconds. The QTC interval calculated using Bazet's formula is 407 milliseconds. The QTC interval calculated using the Fredericia and Framingham formulas is 438 and 421 milliseconds, respectively. Atrial repolarization waves, also called T waves, are rarely visible on an ECG. They most often appear during tachycardia, including during exercise testing. Their polarity is always opposite to that of the P wave. The duration of the atrial repolarization wave is usually 3 times longer than the P wave duration. The mean value is 320 milliseconds. The amplitude does not exceed 2 mm. The atrial repolarization wave forms a parabolic curve. The descending part of the curve is the P wave and the PR segment. The ascending part is the ST segment and the T wave. In leads with a positive P wave, the T wave is negative. In leads with a negative P wave, the T wave is positive. The atrial repolarization wave is often observed as downsloping PR segment depression and upsloping or occasionally horizontal ST segment depression. The atrial repolarization wave is clinically significant because it can mimic ECG abnormalities seen in myocardial ischemia. Positive atrial repolarization waves are rarely seen and can mimic ST segment elevation, simulating acute myocardial infarction. This is a normal treadmill test with prominent atrial repolarization waves. Supraventricular extrasystoles are premature beats that originate from the atria or the atrioventricular junction. The QRS complex may or may not be preceded by a P wave. The last one is usually inverted. However, it may be positive. Its morphology differs from that of a sinus beat. Supraventricular extrasystoles are frequently found in healthy individuals. Ventricular extrasystoles are premature beats that originate in the ventricles. The QRS complex is wide and is not usually preceded by a P wave. A discordant displacement of the ST segment is typically seen. The polarity of the T wave is usually opposite that of the QRS complex. Infrequent ventricular extrasystoles are often seen in healthy individuals, but frequent ventricular extrasystoles are usually associated with cardiac disease. Thank you for watching this video. Please like and subscribe.